weekly imaging conference. We're pleased and honored to have Dr. Panithia Charion-Taitui with us here. She has a very distinguished background. She was born in Thailand, but she moved to the U.S. at a young age, and she did undergraduate work in Columbia University. I was interested to learn that she was a varsity volleyball player. And then she went to medical school at Northwestern. And then after that, she went in 1992 to Rochester, Minnesota for Mayo Clinic and has stayed there for 30 years. Over 30 years, it must be very cold there, but she says it's a nice warm winter this year. I first ran into Dr. Charion-Taitui. I think I remember seeing her at one of her numerous posters that she presented in the 90s. She didn't know who I was there, but the name was interesting, so I went look, and the work that she did was interesting. And she was among the people that mentored her was Ray Gibbons, who's very well known in not only the nuclear cardiology field, but in cardiology in general. He was president of ACC at one point. So Dr. Charion-Taitui has had a distinguished career. I saw she won 3 Teacher of the Year awards during her residency. She's been a course director, faculty, 150 regional, national, international meetings. Often you'll get in the mail a Mayo Clinic cardiology symposium in some nice place, and you'll almost always see her name on it. She's authored over 145 scientific manuscripts. And she is now the president-elect of the American Society of Nuclear Cardiology. Some of the writings I saw years ago, a nice review of Viability. She's done the guidelines for sarcoidosis. Whenever I see something written by her, I'm sure to read it. So I'm pleased and honored to present to you Panithia Charion-Taitui. And she's going to talk about FDG metabolic PET imaging, but she's going to talk about 2 clinical situations. One is coronary disease, myocardial viability for assessment of potential revascularization benefit. And then somewhat, even though it uses the same isotope, kind of the opposite, looking at monocyte uptake, macrophage uptake in inflammatory sarcoidosis. And so she will explain it, I'm sure, in a very nice way that will be good for everyone. And let's begin. Welcome.
Great. So thank you so very much for the kind introduction, Dr. Travin. It's really great to see you. It's also a great honor to be here with you virtually today. I'd like to thank Dr. Slipchuk and also Dr. Travin and other organizers of this series for the kind invitation for me to join you. And then thank you all for being here with me today. So before I go on to discuss PET metabolic imaging for myocardial viability assessment and for inflammation, I just wanted to share with you, and let me just try to advance my slide here, this photo. I'm a very proud mom. My older daughter is actually a first-year medical student at Einstein. I sent her the Zoom link today. I don't know, I think she'll join us a bit later. And I do visit, and so I was there for her white coat ceremony. This is where the picture came from. And I will visit again. So if you see me walking around campus, please say hello. And so that's my proud mom moment. I just wanted to share that with all of you. I also have to share with you my disclosures. I've done some consulting work related to cardiac PET imaging, including work with GE Healthcare, Clario, and Ionetics. So now let's discuss PET imaging for viability and cardiac sarcoidosis. And so here are the 3 learning objectives for our 45 minutes here. We'll discuss some important considerations when using FDG for cardiac PET imaging for these indications. And then we'll compare and contrast the FDG PET protocols for viability and cardiac sarcoid imaging. And lastly, we'll summarize the role of PET in identifying viability and inflammation, predicting risk, and guiding management in patients with moderate to severe ischemic cardiomyopathy and cardiac sarcoidosis. So we're going to start with common themes first, for both types of imaging, but pretty quickly their paths will diverge and we'll discuss each in turn. And I'm going to start with cardiac sarcoidosis because that's one of my favorite topics. We'll talk about current indications for performing PET, the protocols, interpretation, diagnostic and prognostic performance, and utility in guiding management. And then we'll discuss viability imaging and do the same. And we'll spend a little bit more time talking about sarcoid. But the first commonality between PET viability and PET cardiac sarcoid assessment is that both tests use FDG. And what is FDG? And so, for those of you not working in imaging or in nuclear medicine, nuclear cardiology, it's a glucose analog that traces the initial transmembranous exchange of glucose from blood into cells or tissues. And its FDG is taken up metabolically in metabolically active tissue, and that does include normal tissue, where we may see physiologic uptake in the heart, for example, because FDG traces glucose and the heart uses glucose to make energy. But we may also see FDG uptake in the heart in areas of hibernation, where there's a shift from aerobic to anaerobic metabolism. We may also see FDG in cardiac inflammation, where there's marked increase in glycolytic activity. And at the same time, though, it's important to keep in mind that FDG can be taken up by any metabolically active cells and many pathological conditions, infection, tumor, and really any shift in substrate utilization. And that's why it's kind of complicated when you're working with FDG at the heart level. So uptake may be nonspecific due to many possible causes. The second common theme to both imaging protocols is that they both require metabolic preparation, but the metabolic manipulations differ between viability imaging and sarcoid imaging. And this is absolutely critical, and we'll discuss this. The third commonality is that they both require perfusion imaging. This provides a roadmap for interpreting the FDG image, and I'll show you examples of why it's so critical. And then fourth, because of the nonspecific nature of FDG uptake, the interpretation of findings on FDG have to be done in the context of all available data, clinical data, and other imaging data. And lastly, there are no to very limited randomized controlled trials on the use of PET imaging in viability and in cardiac sarcoidosis. So these are 5 common points of these 2 very different diseases that both use FDG with perfusion with PET. And so let's first turn to the discussion of assessment of cardiac sarcoidosis with PET perfusion and FDG. So I want to provide a little bit of background about sarcoidosis and as to why it's important, and it may be a review for many of you. So sarcoidosis is a multi-system disease that can affect nearly any organ. The exact cause and pathogenesis are unknown, but occupational, environmental, infectious, and genetic causes have been implicated. And the central role in disease development is an exaggerated T-cell driven immune response to a causative agent in genetically predisposed individuals. And this results in intense inflammation, similar to a brush fire, leading to an accumulation of inflammatory cells, T cells, macrophages, and monocytes. Then, with the formation of these non-caseating, non-necrotic granulomas, as shown here, where I'm pointing, and they can appear in any organ that's involved. And it's shown as these darker purple spots. And this then causes local injury and with time also fibrosis in the affected organ and causes organ dysfunction. And the most commonly affected areas outside the heart are the lungs and the lymph nodes, particularly in the chest. But almost all other systems can be affected, as shown here. And that's why you have variable presentation. It depends on which organ is involved. So the prevalence of systemic sarcoidosis remains low, but is higher than a decade ago. So it's really becoming more easily detected with different imaging technologies. But there's a lot of variability on the prevalence dependent on race, ethnic background, and geography. And patients tend to be young, unfortunately, and more women tend to be affected, except in isolated cardiac sarcoidosis where it just affects the heart. Men seem to be more affected there. Mortality of sarcoidosis remains low, but it's thought to be higher when there is cardiac involvement. And the heart is affected in about 25% of patients who have extracardiac disease. So how do patients usually present? I think the most common presenting manifestation in symptomatic patients is by far heart block. So high-grade heart block, third-degree heart block. This was present in 40% of patients in this clinical registry from Finland. So a young patient with unexplained heart block most likely has cardiac sarcoidosis. Other important manifestations were heart failure, ventricular tachyarrhythmias, and sudden cardiac death, which was the first manifestation of cardiac sarcoidosis in as many as 14% of all new cases. And in these patients who have clinically manifest cardiac sarcoidosis, there's a 10% risk of sudden cardiac death over 5 years of follow-up. This underscores the high-risk nature of cardiac sarcoidosis, and that's why it's important to try to detect it early. So PET is really well suited for the detection of cardiac sarcoidosis for a number of reasons. And for those who don't work with imaging, PET is a very precise nuclear medicine technique that allows us to visualize and quantify many physiologic processes by using different radio-labeled tracers. And so for the purpose of cardiac sarcoid assessment, we use FDG to target active inflammatory lesions, which are really rich in macrophages, monocytes, T cells, and they have high glycolytic activity and so high rates of glucose utilization. And remember that FDG is a glucose analog, so FDG will go wherever glucose goes. And so we'll see disease activity, and PET is the most robust imaging test for detecting inflammation and disease activity. And then second, with PET, we can also perform a concomitant assessment to look for scar or fibrosis using a different PET perfusion tracer, such as N13 ammonia or rubidium-82. But when we're working with FDG at the cardiac level, this is when things get tricky because metabolic preparation is critical, and it differs depending on the reason you're performing the test. And so here we have to suppress physiologic myocardial FDG uptake in order to visualize uptake due to inflammation. If you recall the Krebs cycle, if my daughter's on, she would know it. And the normal heart uses several substrates for energy production. We need a lot of energy at the heart level, free fatty acids, pyruvate, and glucose. So unfortunately, if we do nothing at all to manipulate the metabolic environment, the myocardium will take up glucose and FDG as shown here, and it'll be diffuse. And we don't want to see this. This will make us very unhappy when we are trying to see inflammation. And so if we give the patient a lot of fat, free fatty acids, we can suppress this physiologic myocardial glucose or FDG uptake as shown here, and we will just see basically blood pool activity, and we have the happy face. And so this can then unmask focal or multifocal FDG activity in the inflammatory cells where there's high glycolytic activity, and we have the smiley face back. So the take home point here is that in the evaluation of inflammation at the heart level, we need to shift the heart from using glucose to using more free fatty acids to unmask that FDG uptake due to inflammation. So how do we do this? Because metabolic preparation is critical before patients even come in, they get not only the detailed printed instructions, but they also get a phone call from our nurse, and they emphasize the importance of the prep and answer any questions. We instruct patients to consume high-fat, low carbohydrate meals now for 2 entire days,
Uh,
and they also fast overnight for 2 nights. This differs from the guidelines that we wrote up,
mm,
and we'll talk about that. They're instructed not to exercise for at least 24 hours before the PET because exercise can bring in more glucose uptake in the muscle, in the heart. And heparin may also be used because heparin promotes lipolysis and increases free fatty acid availability. So in the Midwest, our cardiac sarcoid meals look something like this. 2 whole days, patients have to fry these fatty meats in oil or butter. Some patients really embrace this and love coming back for serial imaging, others not so much. And we emphasize that they should not eat anything else and they can just drink plain water. They have to avoid all the items on this list, even vegetables, which may have high carb content. And for inpatients, it's very challenging. It's hard to do this. Someone always gives them something that they've taken from McDonald's or something. And many medications such as heparin, are commonly in dextrose, and they have to be switched to
Mhm.
saline, or you're going to have a problem. And so we have published our structured patient preparation protocol. This was with the 1 day high fat, low carb meals, and we had a 91% myocardial suppression rate, which we thought was already good. But then others have published higher suppression rates with longer preps. For example, this one from the University of Minnesota, they had a 97% success rate
Mhm.
with 3 days of high fat, low carbohydrate meals and 3 nights of fasting in between. And so we extended our prep to two
Mhm.
days and 2 nights. And I think with this, we're going from 91% to 98%. Now, I get a lot of questions about patients with different dietary needs, vegetarians, vegans, and maybe they have certain, they have to follow halal and kosher meals. And so for those, we'd use this Abbott carbohydrate free soy infant formula, which
Mhm.
it's lactose free, it's gluten free, it's halal, it's kosher, and each can has about 28 grams of fat and 0.26 grams of carbohydrates. It tastes a bit like beer, so not the most popular, and so for 2 whole days, this is what they would look like in terms of their meals, before the PET. So I don't think they embrace this too much, but it is very effective. I also get a lot of questions about what to do with diabetic patients, and the optimal preparation is really not known. We kind of use the same dietary approach with some individualization, but the take home points are really to avoid giving any short acting or rapid acting insulin on the day of the PET and to hold oral agents. And now we have all these injectables. Those should be held while fasting or on the morning of the PET. So once it's confirmed that the patient has followed all these metabolic preparation instructions, then the SNMI and ASNEC expert consensus document recommends that we perform a gated perfusion study, preferably with PET because it's a more state of the art and more precise technique, but SPEC can be used if PET MPI is not available. The perfusion really helps with interpretation, diagnosis, as well as prognosis. The perfusion acquisition then is immediately followed by the injection of FDG. Then there's a period of uptake, which is anywhere from 60 to 90 minutes. We use 60 minutes, and whichever one you use, it's important to be consistent because these patients will come back for serial imaging. And then after the uptake period, dedicated cardiac imaging is performed. And then with the same injection of FDG as for the cardiac acquisition, we do a limited whole body acquisition, which is also recommended by the expert consensus document. And it should include at least the chest, liver, and spleen where sarcoid likes to go. And this could be done if there is not a recent evaluation for extracardiac disease. And this not only helps with diagnosis, prognosis, and management, but also potential extracardiac biopsy sites could be identified because it's harder to biopsy the heart. So interpretation really requires a lot of quality control, visual assessment of the images, using both the normalized cardiac display as well as the hybrid general nuclear medicine display. And this is because the normalized cardiac display may accentuate very mild uptake of FDG due to the normalization process. We also perform adjunctive quantification. And so let's look at this first case to illustrate a few points. He's a 41-year-old man, so young, and he has biopsy proven pulmonary sarcoidosis, and now he has unexplained complete heart block with presyncope. So a very typical classic presentation. And I show you the perfusion image here in the first column, FDG in the second column, and these are standard reconstructed views, short axis cutting through the heart, horizontal long axis, and vertical long axis. And there are moderate to severe perfusion defects. I'm pointing here in the inferior apex, mid-inferior wall, and then in a different spot in the basal, anterior, and anteroseptal segments. And in all of these areas, we see concomitant FDG uptake. So right here where I'm pointing and here. And so this is kind of that PET perfusion metabolism mismatch, and this is compatible with active inflammation and cardiac sarcoidosis, especially given his known biopsy proven pulmonary sarcoidosis. The location of the uptake here, especially in the basal septum, This is very classic also for cardiac sarcoidosis. Cardiac sarcoid likes to go to the septum. So we also gave the perfusion images and we can assess global and regional function, but I don't show the images here. And I know some of you like to look at these images in color. So the perfusion defects here with concomitant FDG uptake in the same areas doesn't always have to be in the exact same spots, but it's very helpful when it is. And then we see again the perfusion abnormality and FDG uptake. This is inflammation, and here is on the FDG, and this could be due to arteriolar compression by the arterioles from the granulomas. And so it's important to know this because if we're going to treat patients with immunosuppressive therapy, we need to know if there is disease activity. And other imaging modalities don't give us that. And so here's a limited whole body FDG scan with the same injection of FDG. And here we always want to confirm that we're seeing the cardiac uptake. And we do see that here where I'm pointing. But in addition to that, we also see extensive multifocal metabolic activity. This is all FDG uptake that should not be there in other parts of the body, including the lower neck, the chest, the lungs. All of this white is abnormal, as well as the spleen, and also some in the liver. And so these are all consistent with active extracardiac sarcoidosis, and these are all places that sarcoid likes to go. So I showed you the classic pattern of cardiac sarcoidosis, which is highlighted here, significant perfusion defect with active FDG uptake. So this is consistent with active inflammation, but there are other patterns. For example, in the first row, we have normal perfusion. So no arterial compression or fibrosis or scar, and normal FDG, no FDG uptake at all. So this is a normal study. And if we go to the second row, we have normal perfusion and diffuse FDG uptake throughout the left ventricle. This is probably inadequate suppression of physiologic myocardial glucose and FDG uptake. Then the third row shows us a perfusion defect with focal on diffuse FDG uptake. And so this could be active cardiac sarcoidosis with inflammation in the right clinical setting. And that's very important, the right clinical setting. And then these patterns down here show varying degrees of perfusion abnormalities without FDG uptake. So depending on the clinical scenario, once again, they may represent a treated cardiac sarcoidosis, or it could be scar, or it could be a nonspecific finding. And then whenever you see isolated focal lateral wall FDG uptake without any perfusion defect or any other abnormalities at all, no wall motion abnormalities, no cardiac MRI findings, a normal echo, this is most likely a nonspecific finding. And so what's the performance? We don't have a good gold standard for cardiac sarcoidosis because traditional endomyocardial biopsy has very low yield, about 25%. So this is really a problem trying to figure out sensitivity and specificity. And so I think most experts believe that sensitivity is excellent for PET, up to 80 to 90 or even 100% in some series, but specificity not so good, can be as low as 33%, but I think most are probably in the 70 to 80% range. We may be able to help diagnostic accuracy by using quantification in addition to visual analysis. And here, most software provide SUV analysis. And SUV is a standard uptake value, which is radioactivity concentration in the region of interest divided by the injected dose. Divided by the patient's weight. So it's a measure of the extent, amount, intensity of inflammation. And I think it's more helpful really for serial imaging, where if we see that it starts out at 4.5 here with a certain ratio as compared to the blood pool, and in follow-up it changes, this may be significant. And so this is what our report looks like. We provide a graphical display and then give final impressions that talk about all the things that I've discussed with you and give an impression of whether this is suggestive of cardiac sarcoidosis or not, and whether there is active inflammation, because that's very important for treatment, or whether there's scar. So does the patient that I showed you have cardiac sarcoidosis just because the PET is positive? Well, most cases we don't diagnose now with endomyocardial biopsy, but we use these pathways that I show you here that are called clinical diagnostic pathways. The most commonly used are from these two societies, the Japanese and the Heart Rhythm. And so our patient had these uh, evidence of extracardiac disease as well as high-grade AV block and FDG uptake. So this is consistent with probable cardiac sarcoidosis. And by Heart Rhythm Society, they also most likely have probable cardiac sarcoidosis. And with active inflammation, we can treat patients with immunosuppressive therapy. So how to diagnose isolated cardiac sarcoidosis can also be done with PET as long as we have no evidence of extracardiac disease and we have at least three major criteria based on the Japanese criteria. And then we can also use PET for prognosis. I mean, these come from smaller studies, and the graph shows survival free of death or VT. The worst outcome is really in patients who have both abnormal perfusion and FDG, that's shown in the red line, 3 times increased risk of VT or death as compared to those without the abnormality. And in the same study, focal RV FDG, right ventricular FDG uptake, is very bad. You have a 5-fold increased risk of death or VT. Limitations to all of this is that the studies are small and observational. Now, we can also use the PET to follow disease activity and see how patients are doing with therapy. We just have to do everything the same way, and then we don't have randomized trials to tell us this, but one small study suggests that if there's a change of FDG uptake in the same direction in both intensity and volume by at least 20%, that's significant. So here's the same patient at the 3-month follow-up. And now what you're seeing on the FTG is mostly blood pool activity and not as much myocardial activity. Before it was very bright in the septum as well as in the inferior wall. And how do we know that this is different? Well, now this is where quantitative analysis comes in. Before, the maximum in the myocardium was 4.5. Now the maximum is 2.5. That's the intensity of FDG uptake. So that's a 40%, 44% decrease and could be considered significant. He's also feeling better, which is great. And I think the most dramatic is really this slide. It's a picture of the limited whole body FDG PET. At baseline, you have all this FDG activity all over the place. And then you go to 3 months and you see nothing that is not supposed to, nothing but kidneys are, it's normal to have uptake, but nothing elsewhere. And so this really, all of the inflammation has just melted away with immunosuppressive therapy. It's not all rosy. There are challenges and pitfalls. These are some of the ones that I'll show you here. Inadequate suppression. Sometimes the patient doesn't follow the diet or someone slipped them something, or they follow the diet, but they're in that 10% or that just don't have suppression, and we might see diffuse FDG uptake. So when we were doing the 1-day preparation, we extended it to 2 days, and we would see that the patient would then have no myocardial FDG uptake. And so this was a kind of an approach that we use, and it does increase success rate to go to 2 days. So isolated lateral FDG uptake. This is probably a non-specific finding. Here we see it's just confined to the lateral wall. There are no other abnormalities on MRI or on echocardiography, and the patient doesn't have extracardiac disease. We extended the prep. Once again, we only see blood pool activity and no activity in the myocardium. So this was just non-specific uptake, but it happens. Well, how about this case? This is a very interesting case and ties into what we're going to talk next about. So this is a woman who has pulmonary sarcoid and a remote stent placement in an unknown vessel. And she had just one single episode of heart block when she was hospitalized for an acute illness. So somebody got the PET, and there is a severe perfusion abnormality over here on the perfusion scan image. And here on the FTG, there's concomitant FTG uptake. So is this cardiac sarcoidosis? I mean, if I had the ability to take a poll, I'd like to do that, but you know, or is this something else? Well, Remember that this patient had that remote stent placement in an unknown vessel. It turned out to be in the circumflex, and the stented area was 100% occluded. So the severe resting hypoperfusion and enhanced FDG uptake is mostly due to hibernation. And this has a very strong signals. You could give a fatty diet for 10 days, and I don't know if we'll be able to suppress that. It's possible that she may also have both hibernating myocardium and some inflammation related to cardiac sarcoidosis. I don't know that we'll ever know, but keep in mind severe CAD before performing these tests. Another interesting case with low level FDG uptake and no perfusion abnormalities at all whatsoever. This ended up having a biopsy, this patient, and they ended up having amyloid, classic apple green bifurcations under cross polarized light after Congo red staining. So, no evidence of myocarditis. These are all the conditions that we have seen in our cardiac sarcoid clinic that have a positive PET. And their clinical presentation didn't fit. And so they went on to have endomyocardial biopsy. So it underscores the importance of maintaining a broad differential diagnosis and really performing a comprehensive evaluation with integration of everything, multiple imaging modalities. So when should PET be used? So this is what we put down in the ASNEC SNMI expert consensus statement. We describe 4 broad clinical scenarios where cardiac PET may be useful in patients with known or suspected cardiac sarcoidosis. So the first group are those with histological extracardiac disease, so pulmonary or elsewhere, and abnormal screening for cardiac sarcoidosis. And it's defined right there on the slide for you. Second group are the young patients, like I showed you, with unexplained heart block. Third are those with unexplained VT. Fourth are the patients with proven cardiac sarcoidosis. So even if you got a cardiac MRI that said cardiac sarcoidosis, it may not tell you if the patient has inflammation, and you still need to do a cardiac PET to see if the patient has inflammation in order to decide whether to give them therapy. So remember, though, that despite everything I've shown you, there have been zero published randomized controlled trials of cardiac sarcoidosis in the use of PET or treatment. There have been many small observational studies, but the quality of the evidence that support all of this is fairly low. So there is not great consensus on how to treat these patients. And so I give you a summary of all the different observational studies. They've been small, but I think we mostly treat symptomatic patients with active inflammation. We may try to treat to improve AV conduction disease, left ventricular remodeling, and symptoms and prevent relapse, but we don't have large scale trials. And steroids may actually worsen ventricular arrhythmias. We don't have a way to really identify truly low risk patients. And I think it all requires a multidisciplinary approach and more trials. But despite of that, we do have some protocols that we use from practice. We start with high dose steroids, and we use methotrexate quite a bit at low dose, and then we kind of switch between the two, and we eventually taper off the steroids and go up to maximal dose methotrexate. And we use PET to follow these patients serially. We'll start with baseline and then 3 months. And if they're doing well, they might not have another one for a year. But if they're not doing well, they might come back for more PET imaging. And so that is kind of the summary. We've covered a lot of ground and on the rationale and supportive evidence and the use of PET for the management of these patients, but also really try to talk about some of the technical issues of working with FDG PET at the cardiac level, and really the critical integration of data for interpretation and the lack of RCTs in this area. So in the remaining time, we're going to switch gears. And I think Dr. Panza was there to visit, and he's probably covered some of this already, maybe not specifically about PET in myocardial viability, but it's really used to help us determine whether patients with moderate to severe ischemic cardiomyopathy should undergo revascularization. But they're two very different diseases. And as I mentioned before, they have commonality because they use PET and they use perfusion imaging and FDG, but they're not the same at all. They're really quite different. But let's just talk a little bit about the background. What were we originally trying to do with viability imaging with PET? we were trying to identify dysfunctional but viable myocardium. And the original one was hibernating myocardium, which was traditionally defined as a state of chronic contractile dysfunction due to persistently low flow. And it was considered an adaptive response that occurs at the cellular level to try to keep the cells alive under hostile conditions. And metabolically, there's a switch from aerobic to anaerobic metabolism, from using fat to using glucose for energy production. And there are lots of changes at the cellular and structural level, as well as reactivation of the fetal gene program. And so, depending on the time course, it's believed that contractile function can improve with revascularization in hibernation. Then on the right, there's another type of dysfunctional viable myocardium, which is myocardial stunning. And stunning is defined as a state of contractile dysfunction due to transient ischemia followed by restoration of flow. So you don't need to do anything traditionally. And with stunning, in theory, you just give it time and it'll improve function. And that's in theory. But in reality, I think that all these myocardial states may be indistinct and they may coexist in the same heart or even in the same myocardial segment. And it may be a spectrum of the same process. So that maybe they may all benefit from revascularization. And PET has the ability to identify some of these different types of myocardial states, as well as patients who may benefit from revascularization. So evidence for this, once again, come from observational studies. We haven't done many randomized trials. And this one from the Cleveland Clinic, where patients with early revascularization had superior survival when hibernating myocardium exceeded about 10%. We also have had lots of meta-analyses of thousands of patients. And even though the studies were retrospective and had limitations in their design, collectively, they showed a benefit of viability testing prior to revascularization. With viability, as shown here on the left in this whisker plot, patients had better survival with revascularization here, PCI and CABG better than medical therapy. But without viability on the right, there was no significant difference in outcomes between revascularization or medical therapy. Well, similar to cardiac sarcoid literature, there's a paucity of randomized controlled trials of PET viability imaging in moderate to severe ischemic cardiomyopathy. I think the only one that we probably should mention is part 2, and it's probably been covered, but it randomized patients, 430 with ischemic cardiomyopathy, to PET guided therapy versus standard care. And then if they had evidence of PET viability, revascularization or revascularization workup was recommended. But in the standard care arm, they could do another viability test. So it was not a trial of viability tests or no testing at all. And they had follow up initially at 1 year, but they also have published 5-year data now. And so the primary outcome was a composite cardiac death, MI, and recurrent hospitalization for cardiac cause. And at both 1 and 5 years, the PET arm in red tended to have fewer composite endpoints, but it really was not statistically significant. So a negative main trial. A quarter of patients in the PET arm didn't adhere to the trial recommendations based on PET findings. And when only patients who adhered to the trial recommendations from the PET were included, there was a statistically significant decrease in adverse cardiac events at 5 years compared with standard care. This is similar in the 1-year data as well. So it suggests that PET viability imaging may be best used if you follow the expert recommendations. Um, but this is a post hoc finding, and we have to interpret it with some caution. And it was really cardiac hospitalization that drove these significant results, not death or MI. But I think there is a signal here that PET could be useful. Unfortunately, I think this is all the real sort of stronger data we have. And based on this, there's really not sufficient data to support routine use of PET viability imaging in everybody. And so the decision to revascularize a patient also is so complex. In these patients with moderate to severe ischemic cardiomyopathy. And it's dependent on so many factors, as shown here from the 2022 multi-societal revascularization guideline. And there's anatomy, there's comorbidities, frailty, end-stage renal disease, procedural factors, and even patient factors. And myocardial viability is not even mentioned here. So I think in selected patients, we can do it, but again, it requires comprehensive data interpretation. So how do we do this? It looks similar to this cardiac sarcoid study, but it's different. There's an overview, overnight fast, typically. And then before we start, we want to ensure that the blood glucose isn't too high for this type of imaging, whereas for cardiac sarcoidosis, it's not as much of an issue. And traditionally, we perform PET viability imaging with just a resting perfusion study with either ammonia or rubidium 82. But in our practice and maybe many other practices, a stress study is also performed because stress-induced ischemia has implications for the management of patients. And then we do these two, and then we look at the perfusion images. And if there's a lot of stress-induced ischemia already and very little residual resting perfusion abnormality, we will not go on to the FDG study. However, if there is not much if there is not much stress-induced ischemia and still residual resting defect, we will go on to FDG, which is more involved once we do that because we have to do the metabolic preparation. And this is one of the most critical parts of the study. When we were trying to do the cardiac inflammation, we had to use fat and avoid carbohydrates and insulin to suppress physiologic myocardial glucose uptake to unmask uptake due to inflammation. Here, we are trying to do the exact opposite. The very opposite. With viability imaging, we want to give glucose and give insulin and promote all these viable myocytes to take up as much glucose as possible and then take up FDG so we can detect cellular viability. Again, the opposite of what we did with cardiac sarcoid studies. We're shifting to maximize glucose utilization and FDG uptake. And so there are many approaches to doing this. And they're listed in the top row from blue to green. And the emphasis here is that the more insulin and glucose we give, the better the image quality. And I wouldn't use the fasting protocol. You can see here, you don't see any myocardial uptake at all. But as we move towards the right here, we get better and better image quality because we're giving more glucose and more insulin. And the ultimate is the hyperinsulinemic euglycemic clamp, where we get excellent image quality for the FDG image in almost 99% of our patients. And so there's a couple of ways to do the oral glucose loading protocol. Here's one of them. And if you start, say, with a blood glucose of 125 in a non-diabetic, you will give maybe 25 grams of oral glucose. Then you have to wait 45 minutes, check the blood glucose, and then you give 2 units of regular insulin. And then you wait again another 15 minutes, you check the blood glucose, and you give more insulin. And you keep doing this. It can take a few hours. It's a bit of a guessing game how much insulin to give. Um, but this is one protocol. And then more recently, another protocol from Dr. Schindler's group at WashU, now using IV glucose loading. And here are the protocols, how much to give for glucose, 50% dextrose, or not to give glucose, and then giving insulin according to this table shown on the right. And they reported good to excellent image quality in 95% of the cases. And the duration was only 50 minutes, which is really shocking. It's very short. So I think this is promising and could also be used. We use the hyperinsulinemic euglycemic clamp protocol. And what we do here is we raise the plasma insulin concentration here on the left acutely to a new plateau. And this is shown using the prime continuous insulin infusion. And it's the same. So it's a standardized dose for everybody. So we know what we're giving. It's 1 milliunit per kilogram per minute. And we use a prime continuous infusion. And this level of insulin would normally cause profound hypoglycemia, but we set an arbitrary level of euglycemia. Here we say it's 90 milligrams per deciliter, and we give 20% dextrose using a negative feedback principle. So we have 2 IVs going, and we have a drip in one, and we have 2 drips in one, and we're checking the blood glucose every 5 to 10 minutes. So it's very, very staff intensive and time consuming, but it really does give the most excellent image quality. But I hope I've convinced you that metabolic preparation is critical to successful FDG PET imaging for viability. So once satisfactory metabolic preparation has been achieved, there are several endpoints, but then FTG is injected, and we have to wait another hour for uptake. And then we image the study, the heart. And this entire study can be sometimes several hours, sometimes a whole day, especially if the patient has poorly controlled diabetes. So for interpretation, we look at rest and stress perfusion images first, as I showed you. And then the rest perfusion and FTG are interpreted together to identify the different kinds of myocardial states. So normal myocardium would have normal everything as shown here, normal resting perfusion, normal FTG, and normal regional function. Hibernation would have this segment, for example, of relatively decreased perfusion here in the distal, mid to distal LAD territory, and then increased FTG uptake with decreased function. This pattern has the highest likelihood of contractile recovery after revascularization. And then SCAR has, stunning has normal. This is kind of tough to tell sometimes, normal or mildly reduced, then decrease FDG uptake and decrease function. And with SCAR, everything will be decreased and it can be severely decreased. This pattern has the lowest likelihood of contractile recovery with revascularization. Don't forget about this additional pattern to be aware of, the PET perfusion metabolism reverse mismatch. This is one reason we need the perfusion image, because we might see this where I'm pointing on the FDG. Is this an area of non-viable myocardium or scar, or at least partial scar? It could be, but there are many other reasons for poor FDG uptake. It could be a poor prep, it could be the patient's diet, it could be the level of glucose at the time of injection of FDG, so many other reasons. And if we have the perfusion image, we know that there has to be viability, viable myocytes when we have perfusion, because the perfusion tracers have to be taken up by viable cells as well. So we call this reverse mismatch, and these are viable, these segments. The opposite is not the case. If there's a perfusion defect, we could still have viability by FDG. So we just look at a case and then we'll finish up. So if we look at Mrs. Smith, she's 64, she has class 2 angina, moderate to severe LV systolic dysfunction. She has 3 vessel disease, she has great targets, she has no comorbidities, and she's active. So I think the decision to revascularize her is straightforward, and we don't really need viability testing in this patient. And so she undergoes CABG, and her EF is now 45%, and she's doing well. Mr. Thomas, on the other hand, he's also kind of young. He's 69 and he has heart failure. He's got vague chest symptoms. It's not clearly angina. He has really bad multivessel disease, including 100% mid-LAD, and he has poor LV. He walks with a cane. He's not active, but he enjoys woodworking. I think the decision to revascularize him is more difficult, and it's particularly difficult if you look at his angiogram. His mid-LAD was totally occluded. It didn't appear to have collaterals, and on the delayed images of the left system, the distal LAD seemed to be really small and diffusely disease, and then he has disease also in the distal circ and OM, as well as in the right. So kind of tough. And then if you look at the echo, his LAD territory seems infarcted. One of our surgeons saw him and said, I want a viability test. He had an MRI first, and he was in atrial fibrillation, so images were not the best, and they called it all infarcted and non-viable, especially in the affected territories. And one of our cardiologists decided to get a rest stress PET with viability, and you can see here actually with stress and rest top 2 rows, there is some ischemia, especially in the anterior and lateral segments. And if you're just looking at the bottom 2 rows, there's also evidence of hibernation, particularly in the LAD territory, with a PET perfusion metabolism mismatch, which has highest likelihood of functional recovery with revascularization. In all of these areas, I'm pointing reduction in perfusion with concomitant increase in FDG uptake. There's also a reverse mismatch here, and this is also viable. So a lot of the LV is viable, and he's also got a stress-induced ischemia. So if you look in color, it's also quite impressive. And so the patient ended up having a three-vessel CABG with lima to the LAD, which the surgeon was able to do, and a saphenous vein graft to the posterolateral and to the PDA. And he had a maze and an LAA exclusion device, and he was placed on GDMT. And 3 months post-op, I think his EF is better. It's almost 50%, and it shows improvement in regional wall motion abnormalities. He's more energetic, less short of breath, and he has no chest pain. So he's still using a cane, but he walks more. So I think that, with PET viability imaging and in decision making regarding revascularization, the summary is that I think in selected patients, it can be useful to identify viable myocardium, assess prognosis, and guide revascularization decisions. But it's not revascularization decision is not dependent on only viability. There are many other factors, and I don't think we need routine viability testing in all patients. But if you're going to do it, consider PET because it has the highest sensitivity and negative predictive value among all the viability tests. I think MRI comes close as well. They may be neck and neck, but I think PET has just a little higher sensitivity. And of course, metabolic preparation is critical. It requires expert interpretation and comprehensive data integration and a hard team approach and shared decision making. So we have a lot of take home points, and I'm going to leave you with this that for both viability and cardiac sarcoidosis, remember both of them use FDG and they both require metabolic preparation, but opposite approaches. They both require perfusion imaging, preferably with PET. Interpretation requires integration, and there are very limited randomized controlled trials. But what we know is that it's useful for both of these entities, and always beware of non-specific FDG uptake. That is such a pitfall when working with FDG at the cardiac level. So that is all I have. I thank you so much for your attention and for inviting me.
Okay, you can hear me?
I
Yeah.
do. I can hear
Okay,
you.
good. So terrific, terrific. And we're doing about a couple of sarcoidosis a week. We were kind of slow because we lost our perfusion tracer, but now we got our rubidium back, so we're doing more PET, with transplant patients and so on. But we do a lot of sarcoidosis studies. We were using sestimibie, obviously, in the interim,
Oh,
which is kind of
okay.
tricky because of different
Yes.
sometimes the attenuation correction either takes away artifacts or sometimes it adds artifacts, so that made it difficult. The 4DM had trouble doing the perfusion MIBI with the
Hmm.
FDG and all those things, but we're back with the rubidium now. And viability, we don't do so much. We use the oral glucose and the insulin, so we're just doing it that way.
Okay.
We did
Sure.
have a study. You have to watch out for the insulin resistance in the heart. And once we ended
Yes.
the patient so soon, we saw a blood pool. We brought the patient back, waited 2 hours, and we got an interim at like 45 minutes, and there was blood pool, and we into 2 hours, and then we had a good target to background ratio. So we always have to be careful with that insulin resistance. Left bundle
Yes.
branch blocks get that reverse mismatch. So we sometimes see that. So there's a list of questions. So let me give someone says, thanks, awesome talk.
Thank
But
you.
Aldo Scanone, one of our imagers, I don't know, maybe you know him, Aldo. He said, any vegan diet recommendations during sarcoid prep? And I'm going to throw in, what about tofu? The
Oh,
Japanese have a tofu. I have a picture that the late Dr. Yoshinaga took. I don't even know if you knew him, but
yes, I
he
do.
took a
Yes, I
picture
do.
of different diets and he showed
Yes.
filled with tofu and
Yes.
bonito flakes. And I saw some say you can have tofu, some said not. It depends if you fry it or how you cook it. So, any vegan recommendations and what about tofu?
Yeah, so vegan recommendations, we haven't had as much luck with tofu, but we have had luck with fried avocados. And so I have recommended the patients do that. But if they can, I've tried to push them to consider the infant soy formula that I showed you,
Right,
because
right.
that is, you know what you're giving. It's effective. It's not the best tasting, but maybe they can mix it with a bit of avocado or something and drink it together with some avocado. Yeah.
Okay.
Um,
So tofu is so we shouldn't say tofu is okay.
Yeah, I'm not sure. I think because it's hard to know. Sometimes tofu comes with things in it, and I think that's
Yeah.
the problem. Like sausage, for example.
Oh, right.
Sometimes there's filler in the sausage,
Okay.
and then we get very poor suppression in those patients.
Right.
Yeah.
So there's different, you buy a package, you don't know what's really.
Yes, yes.
Okay, our director of, I think, preventive cardiology, Dr. Osvald, we had Kim Williams here once talking about
Oh,
plant-based
sure.
diets and so on. Anyway, Dr. Osvald's question is, given your diet protocol, have you or do you plan to study pre and post labs, such as lipids, TMAO, etc., as a way to measure the short-term impact of low-carb, high-fat diet on various health metrics? So he said there are measurements you could do. I know there was some lady at Columbia, they were doing some people were doing ketone measurements
Yes,
and all these
yes.
things.
So we are doing beta hydroxybutyrate. We're trying to implement it for all cardiac sarcoid studies so that we have those to look at to see the degree of myocardial suppression and whether if we're seeing just a little bit of isolated lateral wall uptake, maybe
um,
with a certain level of beta hydroxybutyrate, we could say that that is most likely a non-specific finding because the
mm,
patient preparation worked. But I wonder if Dr. Osfeld is talking more about the impact on, lipids and things with just a high-fat diet. It's only for 2 days,
yeah.
and so and they only come back every so often for most patients. Now we've moved to maybe 6 months or even a year. So hopefully, it's not too bad on their lipids.
Yeah. Just talk about this lateral defect. Of course, that's always the tricky one. And I always say the company it keeps. If it extends into the apex, I say, well, maybe that's real. The other
Yes.
thing is, we had a case once here that there was just a focal defect in the basolateral, a focal uptake, and then a
Okay.
perfusion defect.
Oh, yes, if you have a perfusion
Yeah,
defect, it's not an isolated, right,
right.
FDG uptake. It's comes with other things.
So
In
then
those
this, yeah,
in those cases, I would say that's probably real.
yeah, this
Yeah.
person presented with a sudden death.
Yes.
And they resuscitated him. And he also had extracardiac sarcoidosis. And when they did the EP study, they saw his VTAC originated in the place with the
In that
basolateral uptake.
region, sure. And we have had cases of basolateral wall aneurysm as well and
Yeah.
it's completely like very thin walled by MRI, and yet it has FDG uptake. Because I see here, would love the question
Oh,
about
recently too.
input about PET MR. Of
Mm,
course, we have PET MR here. We're trying to do more of our sarcoids there. And I think it would be amazing to what we could do is do the MR and not do the perfusion and then do the FDG. And it would be a shorter protocol perhaps as well, but it would give us morphological, information as well as
mm,
structural information, tissue characterization, and then inflammation. I think that would be really an amazing way to go as well.
mm. I
And
just, yes, I don't see any other questions. Now, sometimes someone comes in with what they think is myocarditis, and
oh,
they're an
okay.
FDG study. And
Yes,
I know giant cell myocarditis you can pick up, right?
yes.
Supposedly. Lymphocytic myocarditis. There was a paper it was in Jack Imaging or somewhere where they said if the uptake's in the septum, it's more likely sarcoidosis. If there's focal uptake, the lateral wall, it's more likely lymphocytic myocarditis. But of course, that could be a false positive. So, I mean, if someone orders a study, I do it. But
Hmm.
sometimes I'm not sure what the results might mean.
Yes, I think it's very tough. I mean, Dr. Goodberlay and I just wrote up a review for circulation imaging on this. And I think it's very tough for myocarditis, especially if it's more diffuse, because as you know, I mean, we can't really
Mhm.
tell the difference between just physiologic glucose utilization. But sometimes we get lucky and it's more focal. But there's very little data on this. um, there's already kind of not the highest quality
Yeah.
data for sarcoid.
Yeah. I see our chief, Dr. Garcia. Do you see his question here? He said any advantage of hybrid PET MR? We talked about that.
Yes.
Hibernation versus stunning. As you know, Dr. Garcia wrote a nice review a few years ago on this topic. And this is it's similar in hibernation versus stunning. So I think you mentioned something about that, but maybe
Yeah, I think it's very hard to tell the difference between stunning and other entities because in stunning, sometimes you'll see a little bit of mild decrease in perfusion and the FDG, maybe normal or mildly reduced. And that could sometimes be non-transmural infarction, which doesn't recover contractile function well. Well, but then other times it seems to be more in the spectrum of hibernation, where it's more of a true sort of PET perfusion metabolism mismatch. So I find stunning very difficult to know. But I think that hibernation technically, can be defined as repetitive stunning. So
mm,
I'm not sure that there is a true difference between the two. And I think here why that's why I think it's helpful to do the stress
for
study
stress, right?
because when you see the stress-induced ischemia, well, sometimes you don't need the FDG, and the metabolic preparation is sometimes so challenging in diabetics that if you don't have to do the FDG, it's helpful. So we sometimes stop there if there is a lot of ischemia and the LV looks viable.
Yeah.
So, yeah.
I tell people ordering the study, you have to decide, are you interested in viability or are you interested in ischemia? That's what you
Yeah.
want to know.
Yes.
And I think
Right.
if you see ischemia, the predictive value for improved LV function and improved outcomes, it's
Yes.
more better positive predictive value. So
Right.
sometimes the test they really want is an ischemia study. And
Yes.
like you
And
said, you do that first. And if there's a reversible defect in a large area, you don't have to bother
right.
with viability. You
Exactly.
have your answer.
Exactly. And it's viable if at rest
Right.
there's
Right.
really good, perfusion uptake
Right.
and yes. Um,
You see the one on masses and tumors with
masses.
FDG, of course, for
Yeah.
tumors and cancers, they
Yes.
do it. I guess you see a mass in the heart. Is it a myxoma or is it something else? I guess FDG would
We
be.
haven't been using FDG PET
Mm,
routinely for cardiac masses or tumors. We've done a few. We've done a few also for pericardial inflammation. We use it a lot for imaging of infection in cardiac devices and valves, usually prosthetic heart valves,
right.
but not so much for tumors. I think those tend to go to cardiac MRI. Yeah.
Dr. Rochlani, she's our sarcoidosis expert. And so this focal on diffuse pattern, you mentioned it as positive. Some of the Japanese people told me once, we don't use that anymore.
Yeah,
In me, it's how heterogeneous. I look at heterogeneous uptake and the
absolutely.
polar plots. But do you see her question here?
I do. I don't
No.
always repeat it. If it's a, very, very low background level of myocardial uptake, but then clearly areas of multifocal FDG uptake in the myocardium, and there are perfusion abnormalities, then I probably wouldn't repeat that test. But if there is not much of a differential, and there's a paper on this, the heterogeneity of uptake. If
Pretty
there's
good.
more
Pretty.
heterogeneity, it's more signifies probably more true disease and a little
Mm.
worse prognosis. And there are programs that can give you heterogeneity. Our program does not, the software.
Well, I guess
So
you can use a coefficient of variation. That's what
yes,
Rory Hakamovich did a study,
yes, you
and
could
they
do
saw
that.
those patients were increased risk of mortality.
Absolutely, yes.
Uh,
And the other thing is to think about using the beta hydroxybutyrate.
mm,
There is a point of care, a machine that you could get when you could put it right in the lab. I think
mm,
we're going to send our patients to the lab to have it drawn. I don't want to get into the maintenance of that machine. But that could also help
beta
because then if
hydroxybutyrate.
you know that you're truly suppressed from the beta BHB standpoint, then it might help you with interpretation as well.
So you have to set up an infrastructure to get that done,
Yes, to
right?
get
It's not
the
just,
test done, and that's
mm,
what we're setting up.
yeah,
And there's been a couple of papers on this. One
mm.
is by Moaz Almala.
All right, so it's worth looking
Yes.
it up. Hey, anybody else? All right, so I thank you greatly. It's so nice to see you again. I hope you come visit your daughter. And if you do, why don't you stop? We're on the West Campus, Dr.
Okay.
DC, and a lot of us are there. There are some folks on the East Campus as well, but if you want to just come on over and say hello, let us know ahead of time, okay?
Yes, absolutely. I don't have any immediate plans, but I will definitely let you know.
Yeah,
And
she's going to
thank
be
you
here
so much.
another three and
Yes,
a half
she
years, right?
is.
So,
Yes.
so
So I
we
will
have more
visit.
winter than you do, I think.
Yes, I will visit. But so great to thank you so much for
Okay.
having me and so great to see you and Thank you, everyone, for joining. It's been such a great audience with
Okay.
so many questions.
Okay, thanks a lot, and
Thank you.
goodbye, everybody, and
Yes,
have a nice weekend. Take care. Bye.
thank you.